an occupational therapist and a tenure-track assistant professor in the Department of Occupational Therapy at Colorado State, which I think is the Rams. Did I get that right? Okay. Go Rams. He completed a master's in occupational therapy at McGill University, where he also did a PhD, and then did postdoctoral training in the Neuroinflammatory Disorders Program here at CHES, where he was one of our inaugural Leong Centre Studentship and Catalyst grant recipients, and has done some wonderful work on participation and environmental determinants of health for children with disabilities and neuroinflammatory disorders. He's going to talk to us today about the PEACH, the fruits of participation, environment, and child health. So thank you.
Thank you.
Looking forward to your talk.
Well, thank you, everyone. Thank you, Al, for the great introduction. It's great to see familiar faces. I was telling many of you, it's a great full circle moment because I was literally sitting in those seats getting the free food and the free lunch as a trainee. Now to be able to join you as a speaker is a great privilege and a pleasure to do so. I have very large gratitude towards the Leong Centre through the Studentship and the Catalyst grant as well. It really was a facilitator, catalyst, quite literally, to my kind of trajectory as an academic, as a researcher. So I'm very happy to be here again to introduce to you PEACH, the fruits of participation, environment, and child health. This was actually the title of my studentship application, and I carried that forwards into my lab name as well. So again, another way in which the young influence a lot of my work. So quick introduction about myself. I immigrated from South Korea with my parents when I was 5 years old. And as I mentioned, I finished my PhD at McGill University. I started as an undergraduate student at Queen's University, and then did my master's in occupational therapy and PhD in Rehabilitation Science at McGill University, and did a postdoctoral fellowship here at CHES with Dr. An Ye in the Neuroinflammatory Disorders Program. Some of the lab members are here today, so thank you all for being here. So my kind of career was shaped by my experiences working at Camp Neighbourhoods, which is a camp for children with physical disabilities. And through my experiences there, that's where I was introduced to the career or the profession of occupational therapy, as well as the instilled desire to kind of, the participation in camp activities, the ability to have fun, just like any other child, was something very novel to me, and such an amazing kind of beneficial, rewarding experience that again shaped my desire to ameliorate the lives of children with disabilities. And the biggest thing that they always share was that campers look forward to two things in their life: it's Christmas and camp. And to be able to be a part of that experience was something that was again very rewarding. I love to run. I just finished the Cleveland Marathon last week, so I am standing, which is very happy to say. I love to make coffee. I love to read and also sleep. But participating in a lot of these different hobbies and the things that I like to do really do give me a sense of joy, meaning, and just fulfillment. So that's why I want to talk to you about participation. So participation, as defined by the World Health Organization, is involvement in life situations. And these life situations can include mobility, education, leisure, and community life. And we know that through literature, participation has been associated with increased cardiovascular fitness and motor skill in children, increased quality of life satisfaction, building identity, self-confidence, and self-competency, as well as fostering peer relationships and a sense of belonging. Along with these benefits, we know participation is also a fundamental human right as affirmed by the Conventions on the Rights of the Child and the Conventions on the Rights of Persons with Disabilities. Despite these benefits, and despite being a fundamental human right, children with disabilities have reported, so 55.4% of these children have reported facing restrictions in play and leisure. 41% have reported restrictions in classroom participation, despite, again, these benefits and being a fundamental human right. Now think I want you all to think right now, how are you able to be here today? How are we participating in this shared experience? Think about the seats that you're sitting in, the door that you use to enter, the shape of the knobs, the support of the Leong Centre and CHES, the opportunities and the time for these rounds to happen. A lot of these environmental aspects has facilitated our ability to be here today and to, again, participate in this shared experience. Now, that's why we think about, or I like to think about the environment. So the environmental factors can include the physical environment. So that includes the built environment. So the space around us, the physical space around us. Also the equipment, like seats, the utensils that are using to eat the food. So a lot of these things that you don't necessarily think about facilitate our ability to participate in life situations. The social environment, so the social support, I've gotten a lot throughout my life, throughout my training, through family, through peers, through colleagues. Also the behaviors that we display with one another that could, lead to certain peer pressures from, our superiors, our supervisors, really shaping our actions. Attitudinal, so the perception of disability itself, the stigma, is a lot of the things that children with disabilities and chronic illness report as being a huge barrier. So stigma or attitudes, societal attitudes really shape the next one as well, the institutional environment. So I'm, coming from the United States, where the political climate is quite precarious, a lot of the funding that has supported many of these support systems for individuals, children with disabilities have kind of shifted. And that shifts our ability to support, of course, these people. The biggest thing I'm sure you've heard north of the border as well is the funding structures that have changed and that really shaped the research that's being done. So the institutional environment is quite important as well. Now, some of you may be familiar with the International Classification of Functioning Disability and Health, which is the ICF framework. So I really like to situate participation being shaped by both the health outcomes, so the health conditions, so being chronic illness, disability, whatever it may be, but really focusing on how environmental factors shape participation and how it could influence that health outcome. Another way in which I like to look at it is the socio-ecological model, another model that you might be familiar with, situating the individual in kind of these nested environments. So starting with the micro, meso, and the macro environment, shaping health behavior, as well as the health of the individual. So with that, PEACH, what I hope to do with PEACH is create inclusive environments that facilitate participation of children with disabilities to improve and foster health among these children. So our overall objective is to create inclusive communities that promote participation and enhance health of children and families, which I think falls very well along with the mission of the Studentship. So my research project or research lab itself is first looking at individual outcomes and associations with environmental factors, identifying and targeting gaps in the environment that could influence the participation and health of children with disabilities, and then creating system level interventions that, again, foster health, foster participation, and health behavior. And upon this foundation, again, is aligned with the Leong Centre's mission of promoting the flourishing of every child and family, on which I wish to build my lab and then continue to build my lab named PEACH. So I spent some time in this graphic, so I hope you appreciate the moving parts there. I thought it was great. All situated in the framework of equity, diversity, inclusion, indigeneity, and accessibility. So EDIA, again, are these words that we can no longer officially or formally use in the United States. So to be able to be here in Canada, back home, to be able to use these words is very, very gratifying, but we do definitely need to take these things into consideration. Just because the political climate has changed doesn't mean these principles don't exist. So keep that in mind. So thinking about relationships between individual and outcomes and environmental factors. first objective is to estimate the extent to which environmental factors like social determinants of health and community characteristics associate with participation in home, school, and community life, as well as physical activity. And to estimate the extent to which environmental factors associate with health outcomes. And the second objective of this area is to see if participation does indeed mediate this relationship. So this kind of filling this or addressing this area was my work here at CHILD-CHII, working with individuals with pediatric onset MS with Dr. Ann Ye in the Pediatric Neuroinflammatory Disorders Clinic and Program. So we know that 2 to 10% of MS cases are pediatric onset. We also know that upwards of 75% of these children report symptoms of depression and fatigue, and that the disability that they experience throughout their lifetime is much higher than those with adult onset MS. Now, what we're hoping to do is to identify factors that associate with depression to be able to create tailored interventions to improve some of these outcomes. Now, one aspect that I looked at with the support of the Leong Centre was looking at racial identity and social determinants of health. Now, we know that racialized children and youth have elevated risk for mental illness in adulthood. They also experience racial discrimination that has been associated with depression, anxiety, and decreased self-esteem. And that social determinants of health, again, influence both the perceived racial discrimination and is influenced by racial identity. Now, adults with MS living in greater deprivation and lower socioeconomic status are likely to be Black or Latino. They experience greater neighborhood deprivation that again associates with prior depression, anxiety, disability progression, as well as burden of comorbidities. Now, what we're hoping to see is where these children lie. So children with pediatric onset MS, they have these intersecting identities, first of being a child, so not having the agency to, or the independence to make decisions. So that vulnerable population, overlapping with having a chronic illness, along with their racial identity, if they are indeed racialized, that intersecting identity, and living in different neighborhoods that might have different neighborhood marginalization. So what I wanted to see was what are the relationships between these factors among pediatric onset MS, and if they do differ from children who don't suffer from a relapsing chronic condition. So again, looking back at what are the factors that associate with depression so that we can create these tailored interventions for these individuals. The objectives were to estimate the extent to which racial identity, neighborhood marginalization, and depression in individuals with pediatric onset MS are associated with depression. In comparison to a monophasic acquired demyelinating syndrome. So what this is a condition where the child has a single isolated episode of neuroinflammation and doesn't present with chronic factors or chronic health outcomes. The hypothesis is that being racialized and living in more marginalized neighborhoods would lead to an elevated depressive symptoms in pediatric onset MS, but not in the non-chronic neuroinflammatory condition. So the participants, so we did a secondary analysis of the clinic registry that we have here at CHILD-CHII. So we looked at individuals who were diagnosed with MS, and also, like I mentioned, individuals with a monophasic acquired demyelinating syndrome, which is a single isolated neuroinflammatory episode. Inclusion criteria is outlined above, between 8 to 12, speaking English as a native language, or more than 2 years of schooling. Depressive symptoms were measured using the CSDC, with higher scores leading to increased severity of self-reported depressive symptoms. We also used a cutoff score of above 10 to indicate higher severity of depressive symptoms. So looking at both as a continuous and a dichotomous variable. The exposures we looked at was racial identity, which were self-reported and categorized based on the Canadian Institute of Health Information race categories. So they were also they were used at specific racial groups, as well as a grouped racialized group. Again, looking at it more dichotomously in comparison to non-racialized or white individuals. Neighborhood marginalization was measured by Canadian Marginalization Index, which has 4 subdomains: household and dwellings, material resources, age and labor force, immigration, and visible minority. So higher index scores meant greater marginalization. So just based on sex, we see individuals with MS, typically what we see with MS as a whole, so around 66%, 2/3 were female. They had significantly higher depression compared to the mono-EDS or the single episode of neuroinflammation group. They were similar in terms of their racial identity, as you can see here. So 43% were white in MS, 41% in mono-EDS, racialized 57% and 59% respectively. So our first finding is being racialized or South Asian, being racialized Black or South Asian associated with elevated depressive symptoms in pediatric onset MS, but not in the mono-ADS group. In, again, the MS cohort, the higher depression scores were associated with better household and dwelling scores in racialized individuals. And those who scored over 10, so having higher severity of depressive symptoms, had lower marginalization index difference scores for household dwelling, so better scores for household dwelling subdomain. So living in the highest quintile of neighborhood marginalization, compared to white individuals, Black individuals had higher odds of living in the highest quintile of marginalization for material resources. Racialized Black, South Asian, Middle Eastern individuals had higher odds of living in a neighborhood, which are highest quintile of marginalization for immigration and visible minority. Again, these associations were not found in the mono-ABS group. So what does that tell us? So when it comes to depressive symptoms, racialized pediatric onset MS, so racialized individuals with MS had higher depressive symptoms than white individuals with MS. This association or this difference was not found in the mono-ADS group. So that kind of leads us to think about, okay, maybe some of the compounding effects of having a chronic illness and being racialized. Lower depression associated with higher household and dwelling marginalization. So higher the depression, better the marginalization. That can be explained by what the household and dwelling marginalization score consists of. And that consists of, one of the indicators is size of the household. So higher the size of the household, higher the household and dwelling marginalization. So that gets us to think about maybe the potential influence of social network size, which was another study that I'll talk about later on the mental health or the depression outcome. Black individuals with pediatric onset MS lived in higher marginalized neighborhoods, higher odds of living in deprived neighborhoods. And this kind of asks us to think about more of these questions of like, what is it about this specific population that leads to these poor outcomes? Again, like I mentioned, one of the studies again supported through the Yejong Centre was so what we found was that larger social network size associated with lower anxiety, and among these youth, larger social network size associated with having lower anxiety symptoms and lower depression as well. So that's kind of what this slide shows us here. So thinking about what is it about the household and dwelling score that could influence that finding. Now, again, we thought about, okay, now we know the environmental factors. What are some of the health behaviors that we can look at, again, to improve symptoms in this population? So going back to 2 to 10% having pediatric onset MS, 75% of these children reporting depression and fatigue. What we found in literature was that increase in physical activity has been associated with lower depression and fatigue in this population. So we want to look at physical activity this time to, again, improve health outcomes of this population. But what we also know is that amongst this population, they do not participate in enough activity, so moderate to vigorous activity, to have a health benefit for that. So again, going back to, okay, what are other factors that facilitate this moderate to vigorous physical activity to, again, with the ultimate goal of improving symptoms with this population? So we looked at, again, social network characteristics, thinking about those social environment that we found in the previous study. So based on social network theory, social network is a number of social actors connected by interpersonal relationships surrounding an individual. And that leads to social support, which further influences health behavior based on this theory, Berkman's theory. We know that amongst healthy children and youth, social network size has been associated with increased physical activity. And that's similar in adults with MS. Social support has been associated with higher physical activity. And based on a qualitative study we ran with children with multiple sclerosis, social support was important in participating in physical activity. But we didn't have the specific numbers to see what the relationships are in children with multiple sclerosis. So what is the relationship between social networks, social environments, and physical activity participation in this population? And again, does it differ from a non-chronic single episode of neuroinflammation? So our objective for this study was to estimate the extent to which social network characteristics are associated with physical activity in children with MS, in comparison to, again, a monophasic acquired demyelinating syndrome, or mono-ADS, which is a single isolated self-limited illness without those chronic aspects. Participants were again recruited from the Pediatric Neuroinflammatory Clinic here at CHES. Inclusion criteria 8 to 19 years old, again, English speaking, gone through English schooling, and again, 2 cohorts looking at MS and mono-ADS. The outcomes that we looked at were social network characteristics. So we looked at social network size, the social support, the different types of support that they receive, the physical activity that the social network participates in, and social network post-secondary education. Physical activity was measured by the CHILD-CHII, which is a self-report frequency of leisure time exercise. And the health contribution score is a sum of the moderate and the strenuous categories, which presents the level or just the sufficient levels of physical activity to have a health contribution. So what we found was that there was no difference in the sex and age when it comes to the mono-MS group. Similar levels of leisure activity or exercise, and differences in social network that we'll look through here. So when it comes to relationships between physical activity and social network characteristics, we see that social network size, emotional support, camaraderie, post-secondary education of the social network, and the levels of physical activity of the social network associated with the physical activity of the child in the MS cohort, but not in the mono-ADS. So larger social network size, as we see here, associates with higher physical activity in the MS group, but not in the mono-ADS group. Higher emotional support and camaraderie associates with higher physical activity in the MS group, but again, not in the mono-ADS group. Greater number of members with post-secondary education associated with higher physical activity in the MS group, again, not in the mono-ADS group. And greater number of members regularly exercising associated with higher physical activity in the MS group, but not in the mono-ADS group. And that was similar for the health contribution scores. So participating in enough exercise to have a health benefit to the child. So we saw those differences. Those who participate more in sufficient levels of physical activity had significantly larger social network size. They had significantly greater emotional support and camaraderie, more members with post-secondary education, and more members regularly exercising. So again, confirming the relationships that we saw with just the regular exercise or the amount of exercise that they participated. We looked at social environment, and we also looked at built environment as well. So this was also supported by the Leong Centre. So we also saw that having access to greater green space at 500 meters, positively associated with physical activity. But again, in contrast to what we hypothesized, number of intersections at 1,000 meters or a kilometer negatively correlated with physical activity. And we're thinking that may be due to the safety concerns. So having too many intersections in a specific area may deter children and families to participate in activity. That's another. So looking at the social environment and the built environment correlates with physical activity. Now going on to other types of participation, not just physical activity. This was again, this was the Studentship project that was supported through the Leong Centre, looking at participation in home, school, and community life, both quantitatively and qualitatively, to see if it does associate with health outcomes in this population. So participation in home includes self-care, chores, mobility, and communication. Participation in the community, unstructured and structured peer activities, mobility, and communication in the community. School participation included academic, social, recreational, mobility, use, and communication at the school. And neighborhood included household tasks, money management, scheduling, transportation, and work. So this figure here shows us that participation in the home, neighborhood, school, and community are associated with some of the health outcomes that we looked at before as well. So looking at depression, so higher participation in these domains, lower depression, also lower anxiety, higher quality of life, and lower fatigue. What we also measured here was the perceived barriers of the child reporting, oh, I perceive this amount of barriers. So what we found with the perceived barriers, but in the case here, so kind of what we expect, the higher level of perceived barriers associated with lower participation in each of these domains, participation domains, but higher levels of perceived barriers were also associated with higher depression, higher anxiety, lower quality of life, and higher fatigue. Another interesting finding was that those who were non-white, so racialized, but racialized participants, reported lower levels of home and community participation. And those who lived in a household that made less than 50,000 also reported lower levels of home and community participation. Now, when we did focus groups and interviews with these children, these were kind of the reports of barriers and facilitators according to the socio-ecological model domains. So at the individual level, some of the barriers included MS-related symptoms, medication side effects. Facilitators included intrinsic motivation, personal interests. At the interpersonal level, so more of the social level, the fear of judgment, again, fear of judgment and stigma was reported to be a barrier. Participation, parental support, sibling modeling, and peer companionship were facilitators. Sibling modeling and parental support was really interesting. One child said, oh, because my brother started playing, when my brother was playing baseball, I saw that my parents were going to the games, that was a great time. So I started playing baseball, seeing my brother and the support that came from the family. In terms of at the organizational and community level, the rigidity and the structure and schedule of school, academic pressures, limited transportation around the community were reported to be barriers. Having accommodations from the school, flexibility with coaches, proximity to different spaces, buildings, opportunities in the community, as well as access to resources and equipment were facilitators. At the larger policy level, limited awareness of multiple sclerosis or chronic illness in schools, they felt like they weren't able to share the diagnosis or have feel the right amount of support. Facilitators included opportunities, pathways to continue activities. So one example was in sports, starting at the municipal level and then going to provincials and then nationals and then internationals. So having those pathways did facilitate participation, as well as having awareness initiatives at the school level, at the class level, when the teacher or the principal or the school were able to share some of that information about or awareness about chronic illnesses. It created an environment of support. Now, in future, right now, what I'm doing is there's a kind of a Colorado equivalent in Colorado to SickKids at Children's Hospital Colorado. There's a neuroinflammatory clinic there that we're collaborating with to look at. Okay, we did look at that social network, that social support, but what is it within that social network that leads to better health outcomes, health behaviors? So looking at caregiver dyads to see if physical activity, health behavior of the caregiver, the mother and the father, associates with the health behaviors of the child. And again, continue to look at environmental factors in a different country, in a different state, how that associates and influences these health behaviors and health outcomes. Now looking at the second piece, so identifying gaps. I want to identify some of these knowledge gaps in community health and inclusion in this nexus of, okay, we look at rehabilitation and health, community, and policy. In this nexus, what are some of the gaps that we can identify to further support participation in health of children with disabilities and chronic illnesses? And that led to kind of, or is supported by measuring community inclusion. So this piece or this area of my research is informed by community-based participatory research, community engaged research, and initially it was triggered by the province of Quebec as well as the municipality of Montreal. They reached out to our lab saying, hey, we're hoping to create healthier communities, healthier cities for children. And we're putting together an accreditation process that municipalities can kind of get a stamp of approval that they're inclusive and welcoming of children. And they wanted to add a piece about children with disabilities. So again, initiated by the interest holders is what started the development of the Child Community Health Inclusion that became my PhD thesis. So the Child Community Health Inclusion Index is a measurement tool that was adapted from the original Community Health Inclusion Index, and it assesses the concept of community inclusion for children with disabilities at the facility level. So going through content development, validation, and feasibility testing, we have a live version of this child sheet that I'll share with you a little bit later. So we went through item generation through extensive literature review, looking at outcome measures, assessments, checklists, and best practice guidelines that were published, looking at outcomes of accessibility, inclusion, social integration, as well as participation. So through this iterative process and input from expert panels that included researchers, government workers, parents of children with disabilities, clinicians, community designers, as well as educators, we were able to generate this final list of 199 items sourced from these different sources here. So the framework of the CHILD-CHII is presented here. What the CHILD-CHII assesses is it looks at the community as 4 different sectors. So education, health, public spaces, and community institution organizations. And it assesses these 4 different sectors as 5 different inclusion domains, as you see in level 3. So the built environment and the equipment domain is assessed by the on-site assessment. Program services, staff, and policies domain is assessed by the organizational assessment and the macro community at large assessment. So the CHILD-CHII index is comprised of 3 different assessments. So we then went on to validate the content of this measurement tool through a modified Delphi procedure. The participants were recruited from different interest holder groups, so including clinicians, educators, teachers, government staff, researchers, as well as community organization staff. We also included youth with disabilities and their parents as well in this validation process, and it was across Canada. So following this decision tree, we were we asked them to rate the importance and clarity of each of these items on a 4-point Likert scale, from very important to not important, and then from very clear to unclear. So that is the decision tree. And round 2, we presented reworded important items from round 1, and were asked to choose between the original and the modified version. And in the end, we were left with 13 items and 17 items to be reworded after round 1. You see in the bottom left. And at the end of round 2, all 17 of the modified items were deemed clear by the participants. So in the end, we were left with 49 items in the on-site assessment that assesses the physical site where program services take place, 25 items in the organizational assessment that assesses available programs, resources, and policies, and 27 items in the macro community at large assessment that assesses resources, services, programs, and policies available in the larger communities. There's a facility level and then the community that surrounds that facility. Then we went to test the feasibility of using this tool in real life situations and on real life community facilities. So a purposeful sample was selected within the Greater Montreal region with interest holders from the health sector, the education sector, the community organization sector, and parents assessing playgrounds. So the indicators included the length, difficulty, clarity, and value. And these indicators were established based on important aspects brought up during the development validation phase. And they were able to comment to expand on these ratings. So what we found was that, yes, the tool is comprehensive, it is valuable, and it is very clear. But there was some difficulty with using this tool, and the length itself was quite long. So what the participants noted was that having an online or an e-version of this tool, we just created a simple Google form. Even that was easier to use and compile all the information to facilitate the feasibility and the use of the tool itself. So we're using this tool currently to map out accessible employment pathways for youth with disabilities. It's going to be a town hall meeting right after this, a town hall presentation right after this presentation that I'll have to run to. But using the CHILD-CHII to kind of map out that pathway to employment for youth with intellectual disabilities. It's also been used as a framework informing the Canadian health indicators for children with disabilities, so identifying indicators of well-being of children around Canada. And then what I hope to do and continue to do right now is to expand the psychometric testing of this tool in facilities and communities across Canada and the US. And with that, we have created this online version of the CHILD-CHII that, again, is available for you to use on your facilities, wherever it may be, to create an online repository or platform where it is crowdsourced, families, youth, clinicians, teachers, whoever it may be, that are looking at the environment, inclusion of the environmental factors to facilitate health behavior and participation of children with disabilities. They can go in, complete this measurement, as well as have information to see if a certain facility is accessible or inclusive aspects within the facility that might be needed for their child. So an online tool that's live now, that has been set up, that can be used. Now, going on to the last area of my research program, looking at co-creating interventions, really utilizing the EPIS framework, exploring, preparing, implementing, and sustaining some type of co-created intervention that can facilitate the inclusion of children with disabilities, optimize health, and foster participation. So I've recently been granted the AOTF Community Engaged Research grant to do some of this work. So what we will be doing is, but that title is called Co-Creation of Child-Inclusive Resources Through Community Learning and Engagement, or CoCircle. I do love my acronyms. CoCircle is this process that I'll be talking about, and is done through CSU extension. So what extension is, so Colorado State University is a land-grant mission university. So each state in the United States has a land-grant mission university, and they have the mission to, again, bridge and to address needs, co-create solutions through applied research on campus and across the state with partnership of the community sites. So CSU extension, so these extension sites they exist in every single county within the state. So it's working with these extension sites to go through this circle process. So members of the extension sites, extension specialists, as well as youth and families that they serve, as well as community champions, will be recruited to participate in the circle process. And what the circle process is, they go through an evidence-based training module to make activities accessible for individuals with disabilities. And with that knowledge, they will co-evaluate using the CHILD-CHII, the community facility, and the community itself to identify gaps in inclusion that needs to be filled. And when that kind of list is formed, those gaps are identified, they're able to co-prioritize what is it that they want to address. So creating some of this, again, this co-creation process of creating together an action plan to address and fill the gaps of inclusion, to again foster the participation of children with disabilities and promote the health of these individuals. So this is what I'm doing now. And that kind of brings together my presentation as well as this, my overall research plan. Again, to promote the flourishing of every child and family through interdisciplinary research and collaboration, working with different disciplines, not just in academia, but with community workers, government workers, from different community sectors, in efforts to create inclusive communities that promote participation and enhance the health of all children and families. Now, with that, I want to say thank you for your attention and participation. This is and was my team at CHIS and my new team on the left here at Colorado State. We all have these foam fingers because we're just rated #1 as occupational therapy program in the United States. So very happy to share that too. Thank you.
Thank you, Dr. Yoo. Really nice to see the fruits of your time here at CHIS and with the Leong Centre. And really, I appreciated that you brought up kind of our mission statement as a center, because it really, I think your research really spoke nicely to a lot of what we're trying to promote. I'm going to open up the floor for some questions, comments. Go ahead, Kate.
Well, thank you so much for this beautiful description of kind of the full continuum of your program. I'm curious, you focused a lot on the pediatric onset MS. I wonder if you've thought at all about, or if you've hypothesized that some of the relationships you've identified in that group might apply to other kids with other disorders.
Yeah, thank you for the question. So thinking about not just the pediatric onset MS group, and are there similarities with other disability groups as well? I think many of the, just based on that qualitative piece, many of the barriers and the facilitators that they brought up were similar amongst a lot of the children with different disabilities and chronic illnesses. And that's why even with the CHILD-CHII, we take more of a universal approach to inclusion rather than, okay, for a physical disability or a vision impairment. So what the CHILD-CHII wanted to do was take that comprehensive approach, that it is indeed inclusive. It's a universal accessibility, universal inclusion of all children and all their needs. Of course, we can't be perfectly addressing all of these things, but taking that comprehensive approach, because many of, again, the barriers and the facilitators that the report are shared amongst different populations and are even shared amongst healthy and typically developing children as well. So really promoting not just like specialized programs, specialized communities, but really that universal approach of inclusion and opportunities to participate just for all child and all families to flourish. Thank you.
In the back.
Thank you so much.
you just speak up a little bit?
Oh, yeah. Thank you so much for this awesome presentation. Love the project and all of the results that you got. I think that they. I know that a really huge focus of your study was looking at the barriers for facilitators, looking at racialized and marginalized communities of kids. Have you considered, or like at some point within this program, looking at like the genetic markers that would be associated with sclerosis in the study population and how that may tie into the kind of environmental factors, everything that these kids are experiencing as socio?
That's a great point. So you were talking about some of the genetic factors that might also associate with the socioeconomic factors. I'm not an expert in genetics, but there, I believe, is literature talking about, again, the genetic factors associated with MS is a large field and a growing field that is continuing to evolve. But the specific associations to socioeconomic status and racial identity, I have not looked at. So I can't answer that question directly, but it'd be interesting to see if there is indeed some of those associations. But we have to be careful in the sense that, like, it is a sensitive topic, and historically sensitive topic of like genetic differences between racial identities, right? So asking those questions, we have to be sensitive, but questions that could be addressed and have been, I'm not sure of. Yeah,
Just as an idea, it'd be really cool to see like some of the exposure.
yeah. And again, having these connections and collaborations with Children's Hospital Colorado may again introduce clinicians and basic scientists that will be able to look at some of those aspects. So hoping those collaborations will lead to more interesting questions into genetics and other biological factors. Thank you.
Maybe I'll ask one while people are thinking. So your a lot of the work you did when you were within your neuroinflammatory group here, you compared multiple sclerosis to, I think, mono ADS, you
Yes.
called it. Is that like Guillain-Barré being like the?
No, so it's like that didn't fall under monophasic acquired demyelinating syndrome. So
Okay.
it was things like ADEM.
Okay,
Yeah, so one specific episode
right.
of the neuroinflammation that they experience, but not the chronic aspects
Got
of disability or.
So two questions. One is, were you surprised that you didn't see associations with some of the exposures and the outcomes even in a non-chronically ill group? Like, I would expect that people who have larger social networks are probably having more physical exercise, even if they were healthy controls.
Yeah.
That would be, or the same in your analysis of racialized populations. So that would be my first question. Secondly, is there something unique about those particular chronic diseases, or do you think this has broader applicability? Because people here do work in all sorts of different content areas, and I just wanted to know your thoughts about whether there's something different about this chronic disease as opposed to others.
Yeah, that's a great question. And we were like, our hypothesis was like, yes, those associations may exist with the non-chronic condition as well, but the associations will be stronger in the MS population. But what we found, it was quite surprising that you would think, and also literature tells us amongst healthy children that social networks, social support is associated with physical activity or other health behaviors. But that kind of further affirmed maybe the intersecting identities of like the racial identity, having a chronic illness. If those do have a compounding effect on some of these associations that we find, and if these specific populations do need more of that tailored support to be like, because of a lot of these things that are happening during that time of diagnosis, medication, that they do need a focused attention to, okay, some of the health behaviors that you can participate in to help you with some of those outcomes. The interesting thing about MS, or pediatric onset MS, sorry, I should say, is that you don't see the physical debilitating symptoms. they are, when you see them, they're able to function physically, just like any other child. But it's those invisible symptoms that they've outlined in that qualitative piece of like, we feel this fatigue, feel this, feeling not very good in terms of mood. But it's hard to communicate that with others. It's like, you look fine. What is it like? Why are you not able to come out today? So it's that piece, and then not having or feeling safe to be able to share that condition, to share that, yes, I'm struggling with MS. I have this condition that makes me feel more tired. So it's kind of that vicious cycle of like, that's why focus on creating these environments that that foster inclusion, that creates these safe opportunities to be able to share those conditions, so that even those invisible symptoms can be that awareness piece at the macro level. Like, okay, these things do exist, and other children that might look like me, maybe going through these harder situations when it comes to feeling more tired in terms of mood. That can make it harder for them to participate in day-to-day activities.
Thank you.
Thank you.
Colin?
Thank you for the presentation. Are you going to, or how are you going to measure the impact of the Colorado project? As in, you do all this co-creation for development, and then how are you going to measure what worked, what didn't work?
Yeah, that's a great question. Yeah, and at this point, it is a feasibility study to see if it would be feasible to run these co-creation processes with these individuals. But long-term wise, yes. I think the first indicator would be like, has there been creation of adapted or inclusive activities for children with disabilities in these communities? That would be the biggest indicator. And after participating in these activities, do children participate more? Do children feel better? That's kind of down the line, those primary outcomes that we want to take a look at. So creating first the system and the space for it, because we see some of these associations. Okay, we know these associations exist. Let's create environments to further build those associations or build upon those associations. And once that environment exists, does it have those longitudinal health benefits?
On that note, on behalf of the Leong Centre and CHES, thank you, Paul, for your presentation today. Really amazing to see how everything that you've accomplished, and reminding us always to think about function and participation as key outcomes in everything we do in health, including when we put an equity lens on it. So thank you very much.
Thank you very much.